Good afternoon. I'm Pam Douglas. I run the imaging program here, and it's my very great pleasure to introduce Jeff Carr to you for our talk this afternoon. Jeff is a professor of radiology, cardiology, and translational science at Wake Forest. I don't know anybody. That's a true triple threat there, 3 appointments. And he's also head of, I got the wrong piece of paper. He's also head of the bioinformatics program in their translational medicine core, if I got that right.
Close enough. Center
of Biomedical Informatics. He is a graduate of Vanderbilt Fort Worth College and Medical School, has a master's in clinical epidemiology from Wake Forest, as well as a fellowship at the Leonard Davis Institute at Penn of Health Economics. So he has done epidemiology, he's done health policy, as well as clinical training and fellowships. He was briefly on the faculty at Penn and then returned to Wake Forest, where he is obviously now a full professor in 3 different departments. He is well known in the CT and MR cardiac imaging fields in particular, so he is a cardiologist just with the radiology pedigree. And he has been very active in the imaging world through NIH grants and has served as imaging core and investigators on a number of sort of names you know of NIH trials: the Claude Pepper Older American Center, the Jackson Heart Study, the Cardia Study, MESA, Multi-Ethnic Study of Atherosclerosis, ERIC, the Women's Health Initiative, Cardiovascular Health Study, and more recently has had grants for personally controlled sharing of medical images out in the community, so health system type concerns, and is a very broad and creative thinker. I think you'll enjoy his talk on cardiovascular imaging and informatics today. Thank you.
Thanks, Pam. Can everybody hear me in the back? That's a great introduction. I am giving a totally new talk, and I tried to do something a little different because I was thinking, what am I going to tell my colleagues at Duke before the ACC tournament, but we'll see how it goes. What I figured we'd talk about is imaging informatics, and I was going to try to decide, how would this best play out? What would be most informative? And I thought, in order to really understand where I think I'm going, I had to kind of reevaluate my career, and so I'm going to give you a little bit about my background, which I've broken up into decades, and then we're going to talk about cardiovascular imaging phenotypes and how that integrates into this kind of emerging informatics grid for clinical research, and then talk lastly about some of the translational aspects, and we're going to talk about 2 projects that our biomedical informatics core supports. One is a Siren network that deals with motor vehicle accidents, biomedical engineering, and trauma, and the other is my project, along with Yaron Guz, my co-PI in biomedical engineering on image sharing. So I went back to the beginning. This is one of my first studies. I started out doing technology assessment, and so this is circa 1989. And what was happening then was this idea that you could get a digital chest X-ray. And we had film. We loved film. Film was great. Film was higher resolution, but we could have these lower resolution digital images. And one of the dilemmas was, well, could you identify pneumothorax? And if you were a surgeon, then you knew you couldn't do it on the digital films. They were lower resolution, pneumothorax, a really thin line. You could never see it. So as a resident, I said, well, we thought, well, my mentor said, go out and do a study on this with not much guidance. And I was trying to think, it's really, based on my clinical training, a pneumothorax, it's hard to know when you have a small one, right? Because the treatment is you stick a tube in and you treat it, and you definitely have a pneumothorax then. So how do you do diagnostic accuracy when I look at the film, I say you have a pneumothorax, and then I treat you for it? And so what we did was a really cool study. I thought it was cool because I got to run around the hospital with cadavers. Was we got cadavers and put little catheters in the pleural space and put known amounts of air. And here they are. Here are my patients. It was an N of 3. And they look a lot better than the patients we have in our ICU right now. Their lungs are more aerated and open. And I'll just quickly go through this. What we did was we did a ROC study, multi-reader diagnostic accuracy. I also learned about publishable units. I did everything in one paper. And after the fact, they said, Jeff, this could have been 5 papers. If you really knew what you were doing, you could have broken this up. But again, this idea of diagnostic accuracy, that I learned about sensitivity, specificity, what was truth. I knew truth because I put the error in the plural space. And so this was very good. And I learned about, technology assessment, plain film, standard of care at the time, new digital technology, and it was a great learning experience for me. But on the road to informatics, it was very crucial because I learned a lot about assessing technology, and then I really went to digital mammography and did some work in that area, and that was my first R21 grant. But I began to have problems with this because technology changes so rapidly, and so I knew that the technology was always changing, and so I shifted into population-based cardiovascular research, really to address clinically meaningful questions that required a larger number of patients and needed a more stable platform. And then I also realized that you had to have multiple sites, and you had to be able to address the pace of technological change within the constructs of both your research question and your operational objectives of the study. And so that's really what I've done over the past 12 years. And then what I see myself working in the next decade is this idea of grid computing and imaging informatics, really so that we're all working together in the same direction. So as I transitioned to population-based research, I got involved in looking at calcified plaque in the coronary arteries. Here's a CT scan. You can see the left main. You can see these little white dots. What we ended up doing was basically adding an EKG trigger to a CT scanner. They had it for electron beam CT scanners, but no one had really done that for a conventional scanner. It's interesting, the FDA would not allow me to go into the scanner and get the timing directly off the scanner, so I had to develop an optical device that triggers off the little light that tells you the x-ray's on, and it's required that occurs almost instantaneous with the x-ray tube. So the little lights outside the cath room or in any of your devices really tell you when the x-ray tube is on at the same time. And so we use that to digitally capture the EKG along with the X-ray. Of course, now modern CT scanners have it all integrated, but at the time, that's how we did it. What we looked at, and I put this in because really what I learned to do was to begin to use imaging to develop quantitative phenotypes. And so this is one of our early CT angiograms. And you can see here's the LAD and a little white dot, which is the calcified plaque, and a non-white dot, which is the non-calcified plaque. And we used data from a variety of sources to understand this, that the calcified plaque is really atheroma. And so you're able to identify people that have gone along the spectrum to develop advanced atheroma in the coronary arteries. But the real benefit of it is it's a surrogate for the amount of plaque burden that you have in your entire coronary tree. So when you look at it compared to histomorphometry, the correlation is nearly 0.8 between the number of calcified plaques and non-calcified total atheroma by histology in autopsy studies. And so we were able to develop a series of studies, and so 10 years later, none of this happens fast. So we started in 1999, built the CT scanner. We did this work with Bob Detrano and our MESA collaboration, 6 sites, 6,700 participants, followed for 5 years. And I'll go basically to the same graph that I had with the pneumothorax, looking at the ROC space, that if you look at the Framingham risk score, and predicting heart events, the ROC space or accuracy was 0.76. If you looked at just the amount of calcified plaque, not knowing their gender or age or anything, just their calcium score, it was able to predict cardiovascular death and myocardial infarction with an area of 0.78. So it did better, which is really amazing that the calcium score without age and gender can give you that degree of predictive ability. And what was missing in the literature was, does this add to traditional risk factors? And if you combine the two, the area increases to 0.81. And so the commentary was, well, that's not a whole lot, but it's if you're trying to diagnose disease, moving in ROC space over this amount could mean the difference between having a population-based screening process that works or something that doesn't. So that's what we did with coronary calcium. Here you can just see that as you have higher calcium score, you had more events and that it starts very early. But what, from an imaging informatics, MESA taught me was, how do you do a large study with 7,000 people that has CT, MR, ultrasound? How do you organize the data? What are the pros and cons of keeping the original DICOM source data versus just having the derived analysis data? And so over the past decade, I've been on innumerable calls where we've hashed through all these issues and all the problems and all the mistakes that you can make relative to imaging data in multi-center trials, hopefully. I'm sure next week there'll be a new mistake that comes up that we'll have to deal with. Now, we did a trial, too. So in the Women's Health Initiative, we did a trial, and the interesting aspect from both a science and from an operational point was WHI started before we did this study. And so it was a randomized control trial. Joanne Manson led the project, and the idea was that these women had been randomized to hormone replacement therapy and estrogen. They'd been on the trial for 5 years. Could we measure at the end of the trial the amount of coronary artery disease to see if the estrogen intervention reduced the amount of coronary artery disease? And so they called me up and said, hey, we've got to do this trial, but we've got to do it in about 8 months. So we've got to get 33 sites, cardiac CT scans, get them done, trained, ready to go. Then we want you to analyze, measure, obtain the scans in the next 6 months so that we can then report it. And so what this taught me a lot about was, how do you do things fast and well at the same time, which is something that your group does very well. But for me, it was a real experience as to how you manage multiple sites that could be inpatient, outpatient, private practice, academic, the whole heterogeneity of healthcare systems and imaging devices. So in WHI, what we found, just so that we have a little bit of science, is that the women that were randomized based on intention to treat to the intervention or estrogen arm had a 42% reduction in calcified plaque. And if you did those that were just adherent to the medications, i.e. they took the placebo or they took the hormone replacement, 61% reduction in coronary artery disease or calcified plaque at the end of the trial. So then I'm moving forward across a number of studies to a study that we're going to start publishing a lot from, and that's the Jackson Heart Study. The Jackson Heart Study is a study of African Americans in Jackson, Mississippi. In many ways, it is parallel to the Framingham Heart Study and designed to address that we have relatively little information on African American men and women in the southeastern United States. And so my role and our team's role is to do cardiac CT and cardiac MRI. We're measuring everything from the fat around the heart, pericardial fat, visceral fat, subcutaneous fat, muscle attenuation, muscle infiltration of fat. We have a cardiac MR protocol, which we'll show you a little bit about. So for the CT, obviously obesity is related to cardiovascular disease. And so with CT, we're able to develop quantitative traits, the volume, or I like to say the liters of fat you may have in your abdomen, which is always a good way to put it. So I say, well, you have about 4 2-liter bottles of Coke of fat in your abdomen. That's a lot. It's better to have only 1 liter of fat than 4 liters of fat. So you can see on the CT is very good at allowing us to identify and classify that. And then we have cardiac MR, which gives us really exquisite functional data about the heart, and we'll talk a little bit more about the informatics part of it. And what you have to do is you say, well, pictures are nice, but I need numbers. I need numbers to analyze. I need numbers to know how good the quality is, and I need metrics to know how to treat patient. And so how do you go from images to quantitative data? Well, you generally have a variety of programs. This is a program where we're looking at each of the chords of a shortening of the myocardium in short axis view. This is a program that's actually doing strain mapping. So we lay down these grid tags on the myocardium. It gives us the strain by each little segment of the myocardium. And so you can nicely graph out the strain at the base, the mid, and the apex. You can look at strain rates over time. And so you can see very quickly that you have data, not just a measure of strain, but you have a measure of strain by every little block that you define in the myocardium. And so you can see that the data exponentially increases that you have to manage. We also are very interested, obviously, in atherosclerosis. So we've got a protocol for looking at wall thickness in the aorta. And so it's not just a measure of wall thickness. We're looking at the wall thickness all the way around the aorta in 400 chords. And so that gives you a more detailed understanding of wall thickness, but it also gives you a lot more data that you have to manage in an effective way. This is a measure of pulse wave velocity, aortic compliance. So the idea that you're going from just imaging pictures to function. So you're getting some idea of how does the pulse wave move through the aorta? How does the collagen and changes in the aorta? So we can use the CT to get the calcified plaque in the aorta. We can use the MR to look at how this wave, so we can measure the velocity of the wave. And so it doesn't show as well on this. The red wave is in the ascending aorta. The green wave curve is in the descending aorta. And the delta here is the time that it took the wave to go around the aortic arch. And so that's a measure of what's called pulse wave velocity. As your aorta gets stiffer, it moves faster, and so that's a measure of aortic stiffness. So how do we manage all this? And the way we manage it is through a variety of systems. And, you need to know your ultimate goal, what you're going to do with the data. And I was talking with some people earlier. At the beginning of the study, investigators write a proposal, and they say, hey, I want to measure the ejection fraction. And everybody says, yeah, we want to measure the ejection fraction. So we're going to go out and measure the ejection fraction. But it's almost guaranteed at the end of the study, they say, well, I really wanted the ejection fraction, and we like the ejection fraction, but we'd also like the end diastolic volume. Or maybe we need the stroke volume. Or, now I'd really like the LV mass and the stroke volume, but I only want it for part of the cardiac. There's innumerable permutations to, at the end of the study, what you'd like to do with this very rich data. And so it became clear to us that we needed to have a system that saved both the raw data, the source data, as well as all the analytic data and the output that these various programs performed. The other thing that we realized is that I could not afford to pay people to type all these numbers in. Apart from all the errors that would occur, that you needed to have an automatic pipeline that would take the metadata from the DICOM header of the image and link it to the quantitative analyses and the reader workflows that they're doing. And so we settled on a program that was developed by Dan Marcus, who's in St. Louis, called XNAT. It was developed originally for neurofunctional imaging to combine multimodality imaging of the brain with neurocognitive testing, genomics, proteomics for neurofunctional testing. And so we built the first cardiovascular instance of this, that we adapted it from the brain to the heart system. And the brain does certain things and the heart does certain other things. And those concepts, like a beating heart, really don't exist in the brain. And so what we did was define these concepts of, say, cardiac cycle, which really doesn't exist in the brain in XNAT, and implemented that in the Jackson Heart Study. So I was talking to Dan online last night, and I told him I would plug his workshop coming up in June. If you like this, you can go online, and the group from Wake Forest and Dan will be there, as well as some other groups. We'd love to have a group from Duke there as well. But the real advantage for operations from my perspective is we all like writing papers, but part of the shoveling of gravel to build a house or hammer nails is that you've got to keep the operation going. And so I have operation meetings every week, and I needed a tool, a dashboard that allowed me to see how complete our studies, how is everything going. And so we developed dashboards that allowed me to look at how each study, what's completed, and more importantly, to look at quality control as the study occurs. That these analyses are very complicated, and if you don't QC the exams as they're occurring, you wind up at the end of the study with problems. And this is an example of a scanner at one site, and you can see, we do these control diagrams. What we're doing is we're actually plotting the mean CT attenuation, which is the CT measurement of water for each scan, versus this light blue line is their patient weight in tens of kilograms, and this green line is the measurement of noise in the image. And we were like going along September, and then all of a sudden you see that arrow, there's a dip there, and we're going like, why did that happen? Now in this protocol, we're also doing the chest CT on the same scanner, and we didn't see it. And what happened was somebody, during a service call, switched a parameter. It was the pitch value of the helical scan, and we were able to identify it within 2 weeks and fix it without having this offset through the entire scan. So the quality control is like what I do all the time. You can never do too much quality control. And so I am going to do a gratuitous plug for one of the projects that I would like to collaborate with your team here, and that's for MRI calibration. And so we've developed for the Jackson Heart Study this automated QC analysis that tracks temporal drift for MRI scanners using the ACR accreditation phantom. And so what it does is it identifies within the image. You send us the DICOM images. It automatically identifies the objects and measures them, and allows us to develop an automatic pipeline that looks at geometry, ghosting artifacts, homogeneity within a given MR scanner. And so working with Ray Winslow at Hopkins, who's the lead of the Cardiovascular Research Grid, we envision we have a project in the Cardiovascular Research Grid to develop this as a pipeline that anybody in the world could upload their phantom images from their MR scanner, and it would be benchmarked on here versus the database of other MR scanners. And so you'd know if you have a Siemens 1.5 Tesla, is it performing the same or different from everybody else? If you have a group of MR scanners or CT scanners, are they performing similarly on this test over time? The real advantage for operations is that you can automatically see how many subjects you have, how they're accruing over time. This is a list of the readers, how many have analyzed coronary calcium, aortic calcium, abdominal fat, liver attenuation. And so we can go online. I can show you that we can click, and I can see what they were doing this morning. I can log in through the VPN and see if everybody's working or if they're enjoying the beautiful Carolina day here. But the other thing that it does is allow you to kind of look and check the validity of as the study's going. So this is the visceral fat, and you can see that the average amount of visceral fat per 50 millimeters around L4-5 is about 6 to 9 liters in this study. So this is the strain data, and again, this is in 50 studies, and so what we did was we benchmarked our strain data to make sure to the literature, and this is a study that Joao Lima's group and Dr. Rosen did in Mesa. And then for our Jackson Heart Study, we saw that, our peak strain was 14.9, which is exactly what they saw in Mesa after 50 people, and we said, we did this right. It's falling right where we wanted to, and so that makes us know that our QC is working and that we're getting answers very early in the study. Then we try to benchmark each of our values real time versus the literature, and you can see that by having the reporting structure, you can develop the pipelines to go from imaging to QC analysis almost on a as-needed basis, which is really powerful. Now, this is all predicated on using both the data and the metadata. So within DICOM, there's metadata on, which scanner, which time, which series, which image. And so we capture all that metadata and feed it into the database. And really, we use the DICOM variables as the key variables for identifying the participant. That then feeds into our XNet cardiovascular application, which you can see here. It's a web-enabled front end to a database structure set up for imaging. It has a pre-archive where the images flow into, and we have a data manager that says, well, the techs fill out a worksheet that allows us to know if the patient throws up and gets off the scanner, or they have to repeat a series. We know which one's good versus which one's bad, and that happens before it goes into the analytic pipeline, because one of the things that we've also found is that the problem studies come back to haunt you. So you're doing the study, somebody, lightning strikes, the scan's aborted, they call you up and tell you, yeah, we had a problem with 1, 2, 3, 4. So then I would get a call from the analyst, 1, 2, 3, 4, what's wrong with this? I go, oh, yeah, that was the one that the lightning did. So you fix it. Then you do your QC, and they go, well, hey, there's this 1, 2, 3, 4. Why is it different? Oh, yeah, that was the one with the lightning. Then you send it to the coordinating center, and they say, hey, what about 1, 2, 3, 4? And so you're constantly have this set of people that are problematic. And so part of our system is to identify these people and flag these people so that when you get that, okay, here are the outliers. Why are they outliers? What are the real outliers? What are the protocol violations? And so that you identify that up front when people know what happens. And so, again, this is just the DICOM header. And you can see that in many of our MR protocols, we might have 60 scan series that we're looking at. And so we have to manage that data. You end up with a browser here that allows you to get a quick snapshot. This is from earlier in the study, and it'll tell you how many subjects. And I'll try to pull this up live. But it gives you an overview of all the data as it's accruing. So everything from the EF to the end diastolic volume to the strain mapping are in each tab. And then it also allows you to do very simple queries. You can do Boolean or relatively complex. So what I did here was I said, well, show me everybody in the database that has an EF of less than 50% and an end diastolic volume greater than 100 ml. And so you just type it in. It's much like Google, and then it'll spit out. That's the subgroup of everybody in the study that meets those parameters. You can do it for men, for women, whatever variable that you have, you can subset. And this is very useful for doing QC in that you can identify those parameters which are outliers, look for associations. And then we also develop for like the strain data, we use these curves as feedback to the readers and set up quality parameters that you expect certain amounts of noise or certain limits within analyses. And if they're not, they automatically get kicked into a QC review workflow if things are outside the bounds. What I'd like to say now is the XNet is what we call a transactional system. That's part of our clinic operations, or reading center operations. So the images get done, they feed into this database system where we take analytic results, we combine them with the DICOM header, we combine them with clinical reports into one operational database. From that, we generally publish the data, is the way I like to think of it, and extract the data into a more formal data warehousing or coordinating center approach where we pick the variables that the coordinating center is interested in. For example, on the strain data, they may not care about 123 segments model of the myocardium. They may only want a 16-segment model of strain, or they may just want global strain and not regional strain, or they may want it by the anterior wall, inferior wall, lateral wall, septal wall, and we can then, from the database, put the data in the structure that the investigators want and then export that into a data structure that the coordinating center or the end user would like. And so the advantage of having the transactional database is that when you're starting the trial, you capture the data as it comes off the device and the analytic platform, and then you have the ability to then take that and put it into a format that your analyst really would like to see, and you can make that decision at a later time. Now, the idea is, I mentioned the cardiovascular research grid. The idea is that you would like to combine image data, clinical data, EKG data, genetic data, proteomic data, biomarker data into one gigantic resource that you would hopefully know how to use. Now, it is difficult, but you do need to be able to link and organize that data in an effective way. And so the idea is that if we can take the image data and the metadata of the image data and the analytic data and get it organized in a very firm, ontologically sound way, that we need to have the studies name ejection fraction the same way, that how you define things needs to be the same across studies, and you need to understand things, how they're measured. And so one of my studies is Cardia, and everybody says, well, how do you know that CT scanner 1 is the same as CT scanner 2, CT scanner 3? And so we do quality testing, but we have the same problems in Cardia with blood glucose. You know, we've been following these people for 25 years, and so a blood glucose 15 years ago is not the same blood glucose platform as we measured now. Blood pressure is not the same now as it was 15 years ago. We did it with mercury sphygmometers, and now we're using a Dynamap, and there's a systematic offset between those two. And so really, it doesn't matter what you're measuring. You need to have the result and the metadata in a framework that allows you to interpret that data appropriately. And so if we're talking about merging data from different sources, you need both the outcome data and that metadata so that the end user knows how to interpret that data. And that's something that we're working with Ray and the Cardiovascular Research Grid. He's got a very impressive way of handling EKG data with automated workflow, and we're working with him to develop a similar thing for the imaging, that the XNAT transactional system could be merged into the Cardiovascular Research Grid so that if you're doing an echo study, that many of those concepts would already exist and you wouldn't have to reinvent the wheel. Once you have it on the Cardiovascular Research Grid, there's another level of data warehousing. In my role with our Translational Science Institute at Wake Forest, we've built a research data warehouse on the I2B2 platform, which is a project out of the Harvard group and partners, and we're just simplistically, this is a higher order data warehouse that allows you to then take the imaging and merge it with clinical data, cross it with, say, in our research data warehouse, we have 15 years of data, 300 million observations. For, say, like the WHI study, you might want to cross your research study with all women on hormone replacement that you see in your clinical practice or your outpatient practice, and you might want to do some type of studies combined or mapping of that, and I2B2 allows us to do that. We've developed a workflow that allows us to de-identify all of our clinical data into a form that's acceptable for limited data use. We wouldn't make it public, but by signing an agreement, researchers can have access to, in an IRB-approved way, the clinical data for doing cohort description. So let's say you wanted to find a group of people with prostate cancer that you're doing a genetic study, or you wanted to find a group of people with reduced ejection fraction and do some mapping with, say, a research cohort with a clinical cohort. I2B2 allows you to assemble that much like Google's. And we've got a couple of projects. One, we're dealing with identifying methicillin-resistant Staph aureus using a genomics approach. And then the other little hive that we're adding to I2B2 is this imaging component. And those are kind of works in progress that we see developing over the next 5 years. Oops, I think I went the wrong way. Sorry about that. So the real strength of I2B2 is that it allows you to have a very simple query tool for our entire clinical data repository. So in this case, we were looking at ulcerative colitis, and you just go to the diagnostic code, CPT code, drag it into a window. You drag, I only care about men, and I want neoplasms, and then it executes the search across 3 or 4 hospitals and tells you how many matches, and then you can, under a data governance and security workflow that we've designed, submit that to the IRB and then get whatever variables or information from the clinical repository that you desire. And we can talk more about that afterwards. Let's see. Oops. I'm going backwards. So next I want to move to, so we've got this imaging infrastructure. What are some of the translational aspects of it? And this is some work that we're doing with engineers. Joel Stitzel is part of our Biomedical Informatics Center, and he is an engineer, and he's working with trauma and modeling, if you want a hybrid car and you want better gas mileage, you need to have less weight in your vehicle. Now, if you get hit by something, what are the injuries that you're going to sustain? What are the trade-offs of that? And so SIREN is this crash injury research unit, and it's a multi-center study. And what we do is we capture data, such as this person had a car wreck, hit a tree there. And not only do they manage what happened at the wreck, I think my thing is... and here you can see we actually do the deformation of the car, where the impact, what happened to it. And so the whole biomechanical reverse engineering of the accident occurs. But the real thing is we also do the imaging. When they come in as a trauma, we capture their CT scans. We biomechanically model. This person ended up with a cord transection here, you can see. And so we understand how the force of the vehicle translates in to the injuries that we have in the ICU. Everything from pulmonary contusion, pelvic fractures, bone fractures. And by doing this modeling, it feeds back to the Carr designers. So like one example that I'll never forget, we get the orthopedic surgeons, trauma surgeons, us, the engineers in a room, and we go through each of the accidents, and we were looking at pelvic fractures, and what became very clear is if the cup holder was above the level of the seat and you got impacted at the door, you had a pelvic fracture. Those vehicles that the cup holder was below the seat, you ended up sliding over the top and you didn't get the pelvic fracture. So there are fundamental translational issues that by combining medical data with engineering data and imaging data that we're, groups like Joel's are trying to figure out. I got a few more slides. This is our GO grant, which is looking at personally controlled sharing of medical images in the rural and urban southeastern United States. It's a ERA-funded project, so you only have 2 years. So we're working very quickly on it. We just got funding in October, but we've got a network of about 35 sites in western North Carolina, northeastern Tennessee, southwestern Virginia, targeted primarily at underserved population, small outpatient imaging facilities, family practice groups, because we believe that many of these types of people are likely to have the most benefit from health technology, not large academic medical centers. That's our assumption. And part of this project is twofold. One, to develop a needs assessment. What do people really need for sharing images, and which use cases are most critical to patient care in these areas for sharing images. And then secondly, we have a technology development where we're developing a personally controlled sharing system based on tokens of sharing access to images rather than the images themselves. And so we're going to deploy this at 3 sites, the VA system, a rural hospital, Lexington Memorial, and then an underserved clinic in downtown Winston-Salem that caters primarily to Medicaid patients. And so the assessment is really important because, you and I might assume what the problems are, but you go down to the clinic and, I found out one problem was, we have kids born at the hospital and we don't have any records of their chest x-rays and they have pneumonia and they show up here and we don't know what to do. Another use case was TB screening x-rays. We can't get those to the health department. And so how do we move those and how do we handle the permissions for that? And so the needs assessment, what people need and what will help people is critically important. I'm going to show you this. You guys will, if you're in clinical medicine, this is our workflow for outside images in the neurosurgery clinic. Basically, all of these have, wait, no, don't see the image, go back, send to somebody else. Tremendous amount of wasted effort, personnel time, patient time, doctor time, staff time, and we have a health economist that we're modeling how much we could save if we simplify this, so that you don't have some CD that somebody hands to you and say, try to read this, and you have no idea how the viewer works or how it works. And so that's the technology piece, and we can talk a little more about this. This is one of our doctors. We thought it would be really hard to get doctors to take 30 minutes to interview about image sharing, but we have more of a time trying to get them to shut up. They go on forever complaining about this. So this is my favorite quote. On a scale of 1 to 10, with 1 being worst, how would you rate the ease and reliability of the system that you now have for viewing outside images? And I can just, we've got the tape, so I really should play it. And so he goes, so with 1 being the worst, right? 1's the worst. 1 being the worst, probably about a 2. I can imagine him thinking there's probably, I can imagine something worse than what we have, but maybe not. Let's see this. Let's skip. The system that we're doing is a patient-controlled system that's driven by the patient. The way I like to explain it, it's kind of like when you buy gas at the gas pump. You put your credit card in, it says, do you want a car wash? Yes, no. The way we view this is that the patients will have this token. It could be on a cell phone, could be on a card, that would allow them, when they go to a facility, to say, do you want your images from all your other hospitals to be shared with this person? And do you want to share these images with everybody else? Yes, no. And then you can go to sub-menus if you don't want to share. But that would handle many of the HIPAA and other issues related to it. It uses a decentralized approach, much like Napster, for sharing images rather than creating a big archive that all images go to, which is, in our mind, not viable. And it minimizes patient burden. That the idea that my patients are going to go to a website. I don't know if any of you have gone to Google Health or Microsoft and, started your health record. I did like about 10 minutes, but when they wanted me to put in the units for cholesterol and milligrams per deciliter, I'm sitting there thinking, no patient's going to do this. I mean, it's just, until we make it easy for people, they're not going to do it. We also have a big component that allows the provider to control access to images and this promise to share token. So lastly, I want to, for anybody out in the room, who knows what this is? So Pam, do you know what this is? What is this? Oh, I've told you what this is, I think. Anybody else know what this is? It's an echocardiogram. But it's got these colors here. It's speckle tracking echo. Okay? It's kind of like the grid tagging, allows us to do strain. Does anybody know when this was invented or when this kind of came? Is this new or is this old? It's relatively new. The idea's been around for a long time. But part of my roots growing up in Tennessee is, we keep cars in the front yard, old tires. We never throw anything away. We're pack rats. And so I got a call one day that there were these boxes of echo tapes on a loading dock from Cardia. And, they couldn't take it because it might have HIPAA identifying information on it, blah, blah, blah. They were thinking about sending them some undisclosed location with Dick Cheney. I said, no, these are really valuable. So I shipped them to Wake Forest. And so I have like this room of echo tapes from 5,000 people done 20 years ago in 1990. And Joao Lima at Hopkins and I we're doing a new echo exam in these cardia participants. This is going to start in June, where we've got state-of-the-art digital echo. They're going to do speckle tracking echo, and they're going to get strain maps. And I said, well, maybe we could do that on these scans from 1990. And so, what we did was we took these tapes, we developed a workflow to convert 4,000 some odd exams into high raw digital video. It's about a gigabyte, an exam, because you're streaming analog at very high resolution. And then from that, though, we're able to get strain maps from echoes done in 1990, which is the most rewarding thing, that you can save data, you can save information. So now in cardia, rather than being able to look at just prevalent changes in strain at year 25 by echo, we can look at incident, because we'll know that they were normal 20 years ago, and we'll know the ones that were congenital. We'll know the ones that had abnormal strain patterns 20 years ago, and we'll know what's new and what happened. And so the ability to take data, raw data, DICOM data, analog data, VHS data, save your data, because what we'll have 5, 10, 20 years in the future is unclear, and you never know what you'll be able to do with the data that you have in your closet or your storeroom. So thank you, and really appreciate the invitation to come here and talk, and I'll be glad to answer any questions we may have.
That was fabulous. I'm glad we finally got an echo. I just wanted to know, where do you see this going? In other words, you built just fabulous constructs for imaging in clinical research, and for the most careful kind of imaging in NIH trials that are based on imaging surrogate outcomes, like stacks of heart and cardia and stuff. How do you see this progressing in a clinical environment? Am I not on? How do you? I wasn't on. So, how do you see this translating into a clinical trial where imaging is adjunctive to the primary endpoint rather than being the sort of primary endpoint? And then, once you get there, how do you see it progressing into clinical medicine?
Great questions. I think the real problem is that if there is capture, it's much like drawing a blood sample or a DNA sample, that you're taking a sample of a participant and you're storing it. For DNA, you might not know exactly what analysis you're doing. Blood, you store the serum. A lot of serum from the Framingham was, acquired 20, 30 years ago, and now they're running high-sensitivity CRP on it. There'll be profiles of proteomic markers that you can run on stored blood. You've got immortalized lymphocytes that you can actually do experiments in MESA on living cells of participants that were captured, from the blood back in 2000. And so the idea that we're going to capture data, store it in some retrievable way, and then analyze it in the future is that we're going to create these studies, whether they're population-based cohort studies or intervention studies or clinical trials, and they need to really be viewed as platforms for research, that you're going to invest in characterizing, bringing people into a study, and then following them over time. So like in MESA, we have 6,700 people that we started in 2000 to do subclinical atherosclerosis. We got the EPA to do an ancillary study where we put in-house and around the city air pollution monitoring. And so MESA all of a sudden becomes the premier study for looking at how particulate matter can interact with cardiovascular disease. Because we've got GIS mapping of how close the people are to highways, how much particulate matter do they have in their environment, measures inside their house of how much the air outside gets in their house. And so now the EPA is going to come with a much better understanding of how air pollution interacts with cardiovascular disease, because we had the MESA platform and then we added this ancillary study. So on the clinical trials, I could see you might do a study where you just need ejection fraction, but you don't have money to do the strain mapping. You do the clinical trial, then somebody at a later time gets money. As long as you have that source data, you can analyze it retrospectively to get your high-resolution phenotypes once you have a question that's fundable or worth doing. How that would translate into clinical practice is that what we do in clinical trials and what we do in research basically verifies the technique as meaningful. You know, if it's clinically meaningful, then there may or may not be a clinical application. And I think that this is something that, you know, I've had to deal with on grants all the time, is they say, well, you know, how is this going to work? You know, measuring pericardial fat's not practical for clinical practice. You say, well, maybe so, maybe not. I could imagine that if, as in our recent paper, pericardial fat predicts events better than CRP, better than visceral fat, better than coronary calcium, maybe knowing the amount of fat around your heart and the adipocytes are secreting enzymes that interact with the adventitia of the coronary arteries, maybe that's the primary driver. Somebody will build a program that makes it a push-button thing to do. You do the scan, you get the measure. So, you know, it really depends on how valuable the information is. I think on the research side, you need to determine upfront what your key outcome variables are and capture that data and then see it as a repository for future studies. And that's been very useful to our approach with imaging.
Thank you. Maybe Obama will have pericardial fat analysis on his next physical.
He needs to stop smoking.
Jimmy? Wonderful. Thank you very much.